Hello, this is Dr. Williams, and this lecture is Advanced Health Assessment, Nursing 607. In this lecture, the content being discussed is from the Bates Guide to Physical Examination and History Taking. So this lecture should be listened to in combination with the readings from the Bates Physical Examination textbook, and also you can utilize the Bates Pocket Guide to assist you. In this lecture, we will talk about the strategies for effective health assessment. We will go into each of those components, and then at the end, I will conclude by giving you two examples that I will verbally speak to you about, and then you can take the time to try to see if you can do a health assessment based off of the content that I mentioned. And then if not, what areas of the health assessment will be needed to make it a comprehensive health assessment for your patient. Let's start by talking about what are the components of a comprehensive health assessment. It doesn't matter if the health assessment is focused or a comprehensive exam, but what data do you need to collect? So what we're going to be doing is looking at the data that you need to collect for both the comprehensive and the focused exam. And that data we're talking about will include the components of the health assessment. Components such as the client interview and the physical assessment, and concluding with talking about documentation, because that's very important for multiple reasons, and we'll go into that. So let's talk about the SOAP approach that we use with documenting for our patients that health assessment. The SOAP note approach refers to the collection of subjective data, objective data, the assessment, and the plan. So you can see that reflects the SOAP acronym that we use. S, O, A, and P. So throughout this lecture, this is what we're going to be talking about. We're going to be filling in the content that goes into each one of those areas. Okay? So let's get started talking about the functions of your SOAP note and why do we do the SOAP note. Remember, the documentation, also what you'll hear me refer to as SOAP note, is important for multiple reasons. It helps you as the clinician understand what your follow-up will be. So when you see the patient the next time, it also will help your colleagues because we do have a system where providers, patients may be seen by their colleagues. Patients have the right to see different clinicians. So they will be able to understand your critical thinking process and your plan of care for your patient. It also serves as our legal account of what the patient-provider interaction was at the time of the visit. It helps to justify the cost of the treatments, and it allows you to demonstrate to the organization in which you employed what you did in that visit. So now, let's go and talk about the subjective data versus the objective data. So how do we obtain that subjective data? A lot of that information comes from the interview. That is you having a conversation with your patient. Now, there are some strategies that are effective in helping you to interview your patient with collecting their history. So we're going to talk about what those strategies look like and what are their purposes. So one, when you're interviewing your patient, it helps you to establish rapport with that patient. It also helps you in your clinical decision making. It allows you to accumulate and acquire the data, the information you need to document into that patient's chart, the legal record. And it helps with the reimbursement from our third parties to show that the care that you provided requires or should be reimbursed at a certain level. And then it's also important for peer review. Every clinician their charts are peer reviewed periodically, and that peer review protocol or frequency is determined by your institution. However, peers will look at your charting to see if you are charting according to the standards of care, according to the policies and procedures of your organization. Okay? So when we talk about the interview process, know that there are different components that you need to consider with interviewing every client. Are there any cultural differences? And if so, how do you become competent or understand those cultural differences so that you don't offend the patient or the patient doesn't offend you? How do you overcome working with a difficult patient? Or even sometimes the patient may feel you're a difficult provider. How do you handle those type of relationships? How do you and how can you recognize that there may be a communication barrier? And if you do recognize that, are you equipped to be able to utilize some strategies or some tools to limit that barrier? A specific strategy or tool that I know of that I often use in clinic is the translation line. Most organizations have a contract with companies. So you as the provider can call a number. They will inquire as to what language you need, and then they will contact an interpreter that you can utilize. There are diverse ways of doing that. You can do it over the phone. In the practice where I am, we use an iPad. So this way the patient has an interpreter that they can see and the interpreter can see them. And when I get to parts of the exam that may be more private, I can turn the screen off, turn the camera away from the patient, but they can still hear the voice of that interpreter to make it more personable. And then also thinking about another, in a sense, challenge that may occur with interviewing a patient is the patient resistant? That resistance does not have to be one of offense, but it could be that they're just a reserved patient. They don't have the trust in you yet. Or there may have been things that have happened in the past that has prevented them from fully having confidence in the healthcare system. So those are things you need to consider. So now let's get started and let's talk about some of the things that occur in the interview. I think it's important before you begin to see patients that you take time to prepare. Prepare means understanding yourself, doing reflection. How are you feeling that day? Are you tired? Have you had adequate time to review the chart? Is there anything that may limit what you hear or your interaction with your patient? And if so, how can you address it or minimize some of the things that may be a challenge for you? And then making sure that you review the patient's chart and be very cognizant that we are all human and we all have our own emotions and we all have things that may occur in our life, but we have to recognize that as the clinician, you have to take inventory of your own self when you're going to be interacting with others. Okay? Now, it's important to not only get yourself ready, but also as you prepare to interact with your patient, recognizing that we are now practicing in what we term a collaborative model. Historically, medicine was paternalistic. That means the provider came in, they established what the plan of care was going to be for the patient, and they told the patient the plan of care. We no longer do that. We're in a collaborative process. What collaborative management means, we do have an advanced knowledge. We inform the patients of our recommendations, of the rationales why, and then we sit and we have a conversation with the patient to determine what that plan will look like. Patients have a say. This is not us telling them, but it's us working alongside of them. So we negotiate how it goes. Make sure that after your interview is complete, after your health assessment is done, that you need to make sure you close out the interview. That means your patient should be very clear on what the plan of care is, what the expectations are from that plan of care, and what the follow-up is. So what are some of the techniques you can utilize in interviewing to hopefully allow for a successful interaction with your patient? Things like active listening, use of guided questions. That's when you kind of ask the patient, so I see here that you're having some pain. Can you please tell me on a scale of 0 to 10, 0 is no pain, 10 is the worst, what would you rate that pain? Right? That kind of gives them, you're guiding them to the information that you may need. You want to make sure that you display empathy in your responses and you validate them. So as the patient may be telling you, I'm in the worst pain ever, this is not the time for you to say, oh, you don't look like it. This is the opportunity for you to say, I am so sorry that you're having a lot of pain right now. I'm going to try to work with you to get the information I need to see if I can help improve that. So you're validating what they're saying and you're showing some empathy. And then you want to summarize. So if the patient is saying they had the worst pain ever, you may want to summarize that and say, so what I've heard thus far is that you're having the worst pain ever that started 2 days ago and it happened after this. This way it gives an opportunity for the patient to say, yes, you are understanding correctly, or it gives them the opportunity to make some adjustments. Because in the end, we want to make sure that our patients are feeling and understanding that we're listening to them. And when possible, you want to empower your patient. So it's not that we are doing something for the patient. We're trying to empower the patient to allow them to be able to help maintain their health or get themselves back to the healthiest state possible. And that they recognize that they have a part in that. It is not the responsibility solely of the provider. It is for us to partner together. So what do you do when there are times when that interview doesn't seem to be going the way you anticipated it would go, which of course it happens all the time. Knowing and being prepared that at times situations occur that requires us to be able to adapt. Patients may come in, they're very talkative, they have a disability, maybe low literacy, even things such as language barriers or physical barriers. Maybe they have a wheelchair. Things like that may be situations and circumstances that require you as the clinician to adapt how you interview that patient. And if that's the case, then you take time and you do that and address the patient appropriately. An example of a time when I had to adapt was I did have a patient who came in a wheelchair, was a new patient. Our exam rooms are pretty small, and they were having some challenges getting the information out of the patient. So we adjusted and adapted where we put him in one of the triage rooms, which was much larger, allowed him and his family members to be in the room together. And then we would communicate with the family who seemed to be able to speak at that time for him, but the patient was in so much was not feeling well. And then I would verify the information the family member told me with the patient. So then the patient only had to say like yes or no, shake their head. So sometimes you have to adjust and adapt. Now, when you're talking and interviewing a patient, there may be times when you have to discuss sensitive information, or shall I say, there will be times, many times. So knowing what those sensitive topics are and how you feel about those topics is important. As we spoke briefly before, knowing not only your patient, but knowing yourself. So how do you, understanding that patients are going to come in with information about their sexual history that may be sensitive, mental health, alcohol and drug use, family violence, death and dying. These are all areas that can be sensitive. So you as a clinician need to understand yourself and how you respond when you are discussing those information. And if you are one where the saying says you wear your emotions on your face, then you need to work on how do you, in a sense I like to say, keep a poker face. How can you have these conversations without appearing to be judgmental? So note that these are all areas that as a clinician, you should spend time thinking about how are you going to language asking somebody about their sexual history? How are you going to speak with individuals who are mentally ill? What education for yourself do you need to do in these areas? And how do you address sensitive areas like alcohol and drug use? That you're gaining the information, wanting to help the patient to get to have access to resources necessary without being judgmental. Okay, knowing that we are mandatory reporters, so if there are things that must be mandatory that we must report, how do you verbalize that to your patient that comes in, like child abuse and things like that? How do you have that conversation? I would I would propose to you to also have conversations. If you in the organization that you work have social workers, have conversations with them. Know the team that you're working with. You are a provider and you may be the one performing the health assessment at the time, but you have a team of individuals that can help you take care of the patient. You don't do it by yourself. So it may be that the patient presents with a sensitive topic and then you need help from the social worker. While you're in speaking with the patient, you may have your medical assistant start to contact the social worker, contact whatever resources that may be necessary to assist this patient, and let the patient know you will be doing so. There are also some societal aspects that you need to consider with interviewing. Societal aspects like the culture. And are you competent in understanding one's culture? If not, if you have a patient from a different culture, what do you need to know to make the health assessment and effective health assessment visit for the patient? Sexuality and even the ethical considerations. So how do you interview the client? Note that we have verbal and nonverbal communication. The distance, the eye contact, your posture, your body gestures, all are important in your nonverbal communication, as well as the patient. So as you're interviewing, you should be also observing what does the patient's nonverbal communication tell you. Then we have our verbal communication, the use of open or closed questions. Try to avoid jargon, avoid unnecessary duplication of questions, asking the same thing over. Doing things like that can appear to the patient that you're not listening. It may be that you're nervous. It may be that there's a lot of information you've gleaned, but if you keep asking the same question, they feel like you're not listening to them. Silence is very effective. It often can give patients time to think about what they have said and then speak more. It doesn't always have to be a conversation with verbal communication. And at times when there are sensitive subject matters like a death of a family member, sometimes silence speaks volumes. Okay. Now that was the subjective data. Let's talk about your health history. What are we collecting from that for the patient? This is also some of the part of the subjective data. In our health history, this is where you're going to collect your chief complaint, your history of present illness, past medical history, their personal profile, their family medical history, and their review of systems. And we're going to go into this in detail. And you will collect this if you're doing a health assessment for a comprehensive exam or for a focused. And how you structure it will be based on which one. Let's start by talking about the chief complaint. The chief complaint is why the patient presents, what they say they're coming there for. You should be documenting this in quotes. So here's an example. You go into the patient's room. Hi, I am Mrs. Williams, the nurse practitioner. I will be taking care of you today. Can you please verify your full name and date of birth for me? And they will tell you. And you say, how would you like me to address you? It's a pleasure meeting you. Can you tell me what brings you in today? And they'll tell you, I have a headache for 2 days. And you say, okay, so you're here because you have a headache for 2 days. Okay, now let's get some more information about this headache. This leads us into our HPI, our history of the present illness. History of present illness is that chief complaint of why they came in. So now we're going to dig deeper and get more details about that chief complaint. This is where I like to use the acronym OLD CARTS. There are two acronyms, PQRST. Usually I use that if you're talking about pain. But OLD CARTS stands for onset, location, duration, character, aggravating factors, relieving factors, timing, and severity. So let's take that headache for 2 days. That's where the patient comes in and the chief complaint, I've had a headache for 2 days. And I now say, okay, so did the headache come on immediately or was it over time? And they'll say, I woke up and I had the headache. And I say, can you tell me where you feel the headache? They can say in the front, they can say in their side, they can say in the back of their head. And as I will repeat to them, well, you said it was for 2 days, is that correct? Right? That's me using a guided question because that's what they told us in their chief complaint. And they will say yes. And I say, can you describe the headache for me? That's the character. And they'll say, it feels like a throbbing. And the next I'll say, is there anything that makes that headache worse that you've noticed? And they may say, you know, when the light and sound makes my headache seem worse. And I will then say, is there anything that you've noticed that improves the headache? And they may say, I've been taking Tylenol over the counter and it doesn't really seem to work. I think when I just go lay down, I wake up and it's not as bad. And then with that, they've already addressed the timing. They said at night, right? They go to sleep, it gets better. And the severity, on a scale of 0 to 10, 0 is no pain, 10 is the worst pain. What would you rate it? That's how you get through the history of present illness off of the patient's chief complaint. So now let's go into the past medical history. The past medical history is all this information here that you're going to gather. You want to know about any childhood illnesses, any major adult illnesses, high blood pressure, diabetes, migraines, strokes, any of those things you're going to be asking about. Any allergies, you want to know about foods, medicines, environmental, any reactions to anesthesia. You're going to ask them, are they on medications? You want to know the name of the medicine, the dose of the medicine, how often they take the medicine, and when was the last time. Do they have chronic illnesses? Any history of trauma at all or injuries? Any falls? Any head trauma? Have they ever been hospitalized? If so, what month, what year, and where? And for what? You're going to ask them about surgeries. Again, what month, what year, and what type of surgery? You're going to ask them, have they ever had transfusion? What month, what year, and what was the reason? Are their immunizations up to date? If so, you want to specifically know what immunizations. Because as a clinician, remember we talked about documenting. If I don't know, if you just say immunizations up to date, I don't know what immunizations you're talking about. There's a lot of them out there. I need to know the specific immunizations you asked about, because it's not that we are always all comprehensive, but maybe someone didn't ask about the flu the last time, and I want to ask about the flu. And then I find out that they didn't have the flu. Okay? You want to ask about any screening tests. Have they had a colonoscopy, mammogram, whatever is age appropriate and gender appropriate? Any history of psychiatric problems, even anxiety, depression, schizophrenia, bipolar, social stressors. You want to ask about all of those. And then, of course, about health maintenance. All of that. Then we move into family medical history. You want to find out about any major illnesses, any genetic defects, any untimely deaths, or deaths at all, ethnicity, and then you can even draw a genogram. When you are asking about family history, you want to ask about their mother, their father, their grandparents, both paternal and maternal. If they have children, you want to ask about their children. You want to be specific. Do you have boys? Do you have girls? How many? Any health conditions? Okay? A genogram will help you to track different disease processes or conditions in a family. So if you look here, if you've never seen a genogram, you can stop this lecture, take a minute to follow this genogram. Note that there are some common, the common blueprint we use. If you look at this genogram here, circles represent females, squares represent males, okay? And then it's kind of like your family tree, but it's related to the different conditions in the family. On this one, it talks about individuals who were a victim, divorced, anybody had mental illness, things like that. So this can help you track your family. There are electronic versions of genograms where you can go on, you can put the patient's information in with their assistance, and then you can print it out and put it in their chart. You can also, if you really want to be proactive, you can take the same links, send them to your patient. They can complete the genogram before they come in to see you, and that can help you track some things. This becomes really important for individuals who are following like disease processes that may be genetic. So not necessarily are you going to be using those in your practice, but it's a good thing to note. Then you can also see some of our psychiatrists and psychologists use them as well. It is beginning to be used a little bit more in the primary care setting. So now let's talk about personal and social history. Your personal and social history, these are things talking about where were you born? What is your family structure? Are you married? Are you single? Do you have a partner? Do you live with them? Do the children live in the house with you? Do you have any pets, right? Do you exercise? And if so, how often and for how long do you exercise? Frequency and duration. Are you employed? Where are you employed? This comes important when you talk about screening. Do they work somewhere where they're at high risk for exposure to certain things? You want to ask them about their educational level. It helps you know how to interact with your patient. Their religion or their spirituality. You want to ask them about their diet. Usually I use a 24-hour dietary recall. That will be very effective in finding out how they eat. Do they exercise again? And their sleep pattern, how many hours a night? Are they sexually active? If so, do they have sex with men or women or both? How many partners have they had? Do they partake in vaginal, anal, or oral? All helps you in your screening process, right? And do they use protection? If so, what type, right? Because when you think about their sexual practices and sexual history, it helps you know where and how you can educate them. Because if they have multiple partners and they are on contraception, but they're not using condoms if they're a female, they still may be at risk of being exposed to a sexually transmitted disease. That may require some further examination or labs. You want to ask about their tobacco use. Is it chewing tobacco, cigarettes, vaping? If so, how long? How many packs per day for how many years? Do they drink alcohol? How frequently? How many days out of a month? How much do they drink when they're drinking in one sitting? Do they drink liquor, beer, or wine? And then make it comparable to the size of that. Do they use drugs? Do they use marijuana, which is legal, but do they use it? If so, the frequency and duration, right? Do they use any other type of drugs, prescription drugs? You want to ask them about their social activities. Do they travel? What kind of recreation? How do they deal with stress and anger management? All of these are part of your questions. And then are they in the military? Were they in the military? Okay. All of this helps you to understand how to take care of your patient, okay, and make the best clinical decision for them. When I do the review of systems, which is the next section we're going to talk about, I lead this section with my patients trying to control the pace of the video by stating, now I'm going to ask you some questions, and I want you to tell me, are you experiencing any of these symptoms or have experienced them in the last week? These are yes or no questions. Answer yes if you have, no if you haven't. If you answer yes, I will make a notation of it. We will come back to it at the end of the interview. But right now, I just want to get through all of these questions for you. And then I start asking questions, starting at the top of their head, working all the way down. Any confusion, any memory loss, any visual changes, Noticing it looks like something is floating in your eyesight. Any excessive tearing in your eyes. Any headaches. Any pressure. Any hair loss. Any nasal congestion. Any bleeding nosebleeds. Any difficulty swallowing. Any difficulty drinking. Any sore throats. Any problems noticing any cavities or tooth pain. Any bumps or lesions on your tongue or anywhere in your mouth. Any problems with swelling of your lips. Any neck pain. Felt anything in your neck that didn't seem normal to you, like any bumps or any nodules. Any chest pain. Any feeling like your heart is racing, moving, going fast, and you're not running. Any feeling like your heart is skipping a beat. Any lightheadedness, any dizziness. Any shortness of breath. Any feeling like you're whistling when you're breathing. Any stomach pain. Any low back pain. Any constipation. Any diarrhea. Any rashes on your belly. Any swelling of your knees. Any feeling like your legs are giving out. Any numbness and tingling in any one of your hands. Any swelling of your joints. You're walking yourself down the patient's body. Okay, any bruising. So that's what you do with review of systems. And it's yes or no. And then if they say yes to something, you go back and then you now see if you need to apply the old carts to that to get more information. When you're doing a focus health history, you're going to ask the similar information, identifying data, chief complaint, history of present illness, past medical, family, social history, and review of systems. Okay? When you're doing sensitive topics, we talked about this, making sure that you're being non-judgmental. Make sure that you are evaluating yourself as the clinician and your responses so that you can be appropriate, okay? There are tools out there that can be used to help screen patients for these sensitive areas. Make sure that you're using them appropriately, okay? And that can help you to streamline the questions that you need to ask for these patients. Also consider when you're interviewing these patients, your cultural competence, your self-awareness, and respect how they communicate and how you communicate. We as clinicians, we have an ethical and a professional responsibility to our patients, right? And ethics is a set of principles that we define as right and wrong in the medical profession. Non-maleficence, that is, first, do no harm. Never give incorrect information or provide care that will cause harm. That's what we try to do. Non-malfeasance, right? That's what our attempt is. Then we have beneficence. We do good for all clients. We are not there to judge the individual. We are there to provide a service. If there is some patient for some reason that you feel like you cannot provide that care, then it is best for you to refer that patient to another provider who can do it, right? And be objective about it. Autonomy. The client has the right to determine what is in their best interest. The client and the NP should collaborate for care decision making. We do not tell our patients what to do. We inform them and then we help collaborate with them to make the best plan for them. And then confidentiality is key. So what is our objective findings? That is our physical. That is us actually doing the physical exam itself, right? The physical exam usually can match what is done on the review of systems. If not, you're going to be looking at why. If the physical exam does not match the review of systems, normally I think you're going to be thinking about what other differentials, what other things could this possibly be, right? We also use objective data such as our diagnostic tools. This could be our labs. This could be our radiology tests. These are objective tools and ways of gathering information. Together, the subjective and the objective help us come up with our final assessment. It is the copulation of both. It's not one over the other. And when we're doing our assessment, this is where we're making our diagnoses. It may be a diagnosis that has already existed for this patient, or it may be new, right? And then you also have to be thinking of differentials. What other possibilities may it be? So a patient may come in with their blood pressure elevated. They have a history of high blood pressure, but it's always been controlled. So maybe something else is driving that blood pressure up. Maybe they now have a thyroid problem. Maybe they have kidney stones. Maybe they have intense back pain. So the high blood pressure now is a symptom of some new diagnosis. That would be in your differentials. But you determine your differential diagnoses based off of what you have acquired through your subjective and objective data. Okay? Now, we now move from the assessment, which is our diagnosis, to our plan. The plan for your patient should consist of 5 components: non-pharmacological interventions, pharmacological interventions, the educational needs of your patient, and it should be based off of their level of education so that they understand it, or even their language. If they speak another language as their primary language, giving them educational materials in their language, even providing their prescriptions in their language. You can write, when you're sending a prescription over, in the pharmacy note that you would like them to print the directions for the medications in whatever language. For me, most of my patients are like Spanish speaking, so I will say, please print instructions in Spanish. This way the patient's medications is provided to them in their language that they're most comfortable with. Also knowing patients need a follow-up and they may need referrals. So those are 5 things: non-pharmacological, pharmacological, educational, follow-up, and referrals. Okay? Now, just to conclude, I want to leave you with information about knowing your documentation. You want to try to avoid any legal problems, right? So you need to remember what you've been taught. If you have not documented it, you did not do it. When you do document what you have done, especially when it comes down to education, who did you educate? Was it the patient? Was it the family? Was it some other individual that was with them? Maybe they have a case manager, or maybe it was both. Did they verbalize that they understood it? Did you provide that education in written, verbal? How was it provided? Okay, or both. But making sure you document that. Okay. Now, some tips for documenting your patient data correctly. If you're filling out pre-printed forms, make sure you fill them out while you're interacting with the patient. The sooner the better. Record your vital signs as when they're taken. Only record what you've done. If you have not done some part of an assessment, write not assessed, right? You can also use drawings if you're not sure how to explain what you see. And then the other thing is, I would say abstain from using abbreviations unless you know it's a standard abbreviation across the medical field. Because just because if one institution uses a certain abbreviation but another one doesn't, then it can be misconstrued and it could cause harm to the patient. So you want to reduce your risk of having some legal issues by making sure that you only use the standard abbreviations for the medical field. Here is a picture of a chart. Like, you can use this chart. Say you want to say that you saw something on the thigh. You could literally color in where you saw it, right? And then if you needed to say, okay, well, this is what it looked like. It was a linear lead scar. So you can kind of take the area that you want to talk about. So this is, I saw some type say it's a scar here. So I'm just going to try to make this a little clearer for you. So this is the part of the thigh. And then I said it was like a linear scar, and then it had a few dots. That's better for me to say that, a few papules and a linear form, than for me to not be able to explain where I thought I saw it. Okay? So now, in conclusion, let's talk about your documentation. When you look in your medical records, you're going to see that there's a problem list that will be generated. Every diagnosis that you give the patient goes on their problem list. And those diagnoses come from the vast SOAP notes over the history of that patient being seen in care. Again, our SOAP note is our subjective, our objective, our assessment, and our plan. And all the information that you're going to put in each one of those aspects is what we have discussed over these past few slides. Take a minute to think about how you would document your SOAP note. Practice it. So what I would like to do now is just give you 2 different examples that you can utilize and try to see if you can complete your SOAP note. The first one is a 44-year-old female presents to the clinic to be evaluated for a STI screening. The patient's chief complaint: I need to have sexually transmitted disease screening. I was told that my partner had some type of STI and I would like to be screened for it. I'm not having any symptoms. I was just informed by phone. I am healthy. I have no other health problems. I am not allergic to any foods or medicines. I don't have seasonal allergies, and I've never had a response to any type of anesthesia. My family history is unremarkable. Mom, dad are both still alive. They're doing well. My grandparents are all alive as well, and also is healthy. They're just older. I have one brother, no sister, who's also healthy. I don't have any children. I don't smoke. I don't drink. I don't use any alcohol. Okay. I have no complaints, no abdominal pain, no constipation, no diarrhea, no vaginal discharge, no vaginal odor, no itching in my vagina, no burning with urination, haven't noted any change in the color of my urine, definitely haven't noticed any blood in my stool. My appetite is fine. I exercise regularly. I only have one partner. It's a male partner. We do not partake in oral or anal sex, only vaginal. I am on the Mirena. I've been on it now for a couple of years. My menstrual cycles are basically stopped. And that's basically my health history. I'm good. So see what part of that you can do to start doing your subjective, objective assessment and plan. What information would you need? Think about what systems you would want to assess on me. And then what kind of plan would you want to do for me? Okay, or evaluate for me. And then what kind of plan would you want to do for me? The next patient, a 65-year-old African-American female, history of diabetes and high blood pressure, presents for medication refill. Has no complaints today, is only here because her last visit was 3 months ago. Her last hemoglobin A1C was a 7.0. She takes her meds every day. She takes metformin 500 milligrams twice a day, lisinopril 10 milligrams once a day, and Lipitor 10 milligrams once a day in the evenings. She is up on her immunizations. She has no other medical history. She's not allergic to anything. Her family history is unremarkable. Socially, she does not drink alcohol. She does not smoke cigarettes and never use drugs. She exercises 2 to 3 days a week for about 30 minutes a day, doing some walking while she's walking her dog. She eats only what she cooks at home since she's been diagnosed with her diabetes several years ago. She eats vegetables with every meal, and she eats at least one salad once a day, usually with dinner. She does like to drink tea in the evenings with her meal, a sweet tea, but outside of that, she drinks water for the rest of the day. She does consume 2 cups of coffee a day, and other than that, she's doing well. Okay, let's see what you can do with that information. What information do you have? What information is missing? And what would you like to do? What would your plan be for these patients? I hope you gleaned some information from this presentation. Please also review back to your Bates and either the textbook and or your pocket guide, and take the time to review the Bates videos that talk about the documentation, the health assessment. It's going to just help to scaffold the knowledge that you have.